So we're going to go ahead and get started. Thank you, everybody, for joining us. I have Dr. Michael Molter here. He is one of our PM&R doctors and sees patients down in our Washington Township office. He's going to do a presentation tonight, and then we will have about 15 minutes left for questions. We do have a lot of people on tonight, so we will do our best to get to as many questions as we can. If you have an additional question that's a general question, you can feel free to email it to me and I will get an answer back to you. If it's a specific question, and we'll ask, in the chat anyway, if you can keep any kind of specific questions about your own treatment to a minimum. We're going to try to keep it as general as possible. But otherwise, if you have a specific question, we can always set you up with an appointment with Dr. Molter. I will put my contact information in the chat. And that way, if you have any other questions or would like to set up an appointment, you can contact me directly. And I will stop talking now and let Dr. Molter go ahead.
All right. Well, thank you very much. Everybody you can hear me, correct? We're good?
Yes, we can hear you.
Okay. So first of all, I want to thank everyone for participating in this. Had I known this was opening day and the Phillies were playing at 4 o'clock, I probably wouldn't have done it today, but I appreciate everybody that's still on here. I know you're all busy doing things, so to take time out of this and just kind of sit and listen to somebody else talking from their house means a lot to me. And I also realize you have many other places you can go for orthopedic care. So I do appreciate that you come and see us at Rothman, those that are on here that I've seen or have been to us for other reasons. And it's always interesting when I do these, I make sure to bring this about that doing the lectures like this has its pros and cons. The cons of it is you can't see anybody in front of you. And so it's always nice to be able to put a face to someone and not just a name on a computer screen there. The positive is we would never get this many people in our office for a lecture. So it enables us to kind of reach out more to folks that we normally may not be able to get to or can't get to the office. So it does allow us to do that for better or worse there. So what we're going to talk about today is pretty much what I spend all day doing is addressing common misconceptions about and also addressing some treatments for lower back pain of various causes there. Pretty much what I do at Rothman is non-surgical treatment of lower back and neck pain. And so this is something that I deal with pretty much all day. So our goals for today, all right, if I can get my screen to change. All right, what up? What do I have to do? All right, so the goals for today, one is to review the prevalence of spine conditions that we see in the office. The second is to correct any basic misconceptions of spine care. And the third is to identify indications and contraindication for interventional procedures. And why we're doing this is, it just is to go show you the prevalence of the different types of spine disorders that we see, because they're not all the same and not all treated the same there. So that's certainly one thing that we try to address. And then the misconceptions is basically some people come in, we have a preconceived notion of what we're doing as far as treatments are concerned. And so we want to make sure that we're addressing that. Oh, I just figured it out. And again, the third is to identify certain things, whether they're indicated or not indicated for injections, because not everybody needs the same injection. Not everybody has the same type of back pain that we're treating. Not everybody has back pain. Some folks have more leg pain than back pain. So we're going to try to address all those, and it's obviously a huge topic, but we're going to try to get through it the best we can. And again, any questions, we'll try to address the best we can there. And, I'm always in the office and they all know how to reach me. So when we talk about, the amount that spine we see and how much it costs us and in dollars, it's much more than that. Somewhere, sometime, most of us will have low back pain. It ranges from 51% to about 75% throughout our lives. We will have some back pain. And there's a certain percentage of that, and a lot of what we deal with is due to the disc issues in the lower back, particularly those that are disc herniations that are pushing on nerves and causing people varying degrees of nerve pain down their legs and things to that effect. Now, most of the time, that's where we're getting the nerve symptoms from, though sometimes you can just get inflammation around the nerve, and that can cause similar symptoms in regards to that. But again, it's more than the financial costs. It's the costs of life activities and enjoyment that we're not able to do because of these issues we have with our lower back, whether again, if just in the back or the leg or things to that effect. So, being able to hold your child or go out and throw a ball with your son or your grandson or going on a hike or any of these things, aren't things you could just put money down and say, I want to go do this and be able to do it. That's not how it works. We have to get you in the ability to be able to do that. And you can't buy that. It's through treating these symptoms and getting you back to life with this. And so first thing I always tell folks is they come in and they feel that things are never going to get better. And for the most part, that is not true. The reality of it is most back pain, whether it's from arthritis in the back or disc herniation, and whether you have back pain or leg pain, we will be able to improve in some aspect. And that's basically just through conservative treatment. Now, there is always a case where you may not get relief or to complete pain relief. But again, our goal sometimes has to be, we want to be able to get you doing more of what you want to be doing before you have the pain that you're having that limits you. And I always bring that point to patients because sometimes we're just not going to get rid of all of your pain. But if we can make you more functional and being able to do what you want to do, that's obviously where we're headed with this. So why do we treat discs conservatively? Because most of the time, discs will heal on their own. And I have this discussion with patients every day that come in and have a huge disc herniation in their back and look at me in absolute misery. And they give me a look of, there's no way this is going to get better. There's no way this pain is going to improve. But the statistics tell us that 90% of that time it does. So my job is to basically get the patient on that path to where we're managing your symptoms as your body can heal that disc. And the numbers don't lie. The 90% is a pretty great percentage to come in and say to somebody, hey, this is the chance that you have as far as getting better. And that's why we address things from a conservative standpoint there. And most of the times at the end when we're done and they're feeling better, I remind patients, remember how miserable you were when you came in and look how well we're doing now, because, and that's all work that the patient puts in. I just put you on the road to getting there. The patient is the one that actually does all of the work with that. So what we're looking at here is basically a side view of someone's back. And the discs are basically 5 at the bottom and 1 at the top, and in between each of these are the vertebrae. Well, what we're looking at here is a pretty sizable disc herniation at the lower part of the back, and this level that we're speaking of is what we call your L5-S1 level, and that's the most common level where folks get this. Now, I show this picture because as bad as it looks, the more of this disc that is sitting in this space here that knows this disc isn't supposed to be there, the better off this has to heal. Again, little consolation telling this to a patient that's in agony in the office, but the larger that disc is, the more of it sitting in that space, the better chance that space is going to say, hey, you're not supposed to be here, and we'll work to resorb that disc on its own. So, the interesting thing is the larger disc herniations heal much better than when folks come in and just have a little bit of a disc herniation or a disc bulge. Not that we want you to have a large disc herniation, but the percentages as far as healing is concerned are much higher in the aspect of the disc itself with the size that we're seeing here. So another misconception, Used to be, what we did was you'd come in, you'd see your primary doctor. There wasn't anybody specializing in any type of low back pain or anything. So you'd see your primary. They would give you some ibuprofen or other type of medication, have you go home and lay down for a few days. And that's what we did. And we did that because we thought it used to work. And the adage was, more bed rest, more bed rest, more bed rest. That'll help your back feel better. Well, what we found is that's really an old school way to look at it. And over time, we found out that is not the way to go. It really doesn't address the mechanisms that are driving inflammation with us. So to go home and just lay down for days at a time is just going to increase your symptoms and allow that inflammation to increase there. When we look at kind of the cycle of how inflammation works and pain, basically you have pain, it creates tightness in the muscles, you get reduced blood flow to that area, it leads to inflammation, and then you have reduced movement and pain. So what we need to do is break up these areas here where we're not moving so we can reduce this inflammation, improve the movement, and reduce this pain. Somewhere we have to break this cycle, because otherwise, if we just go and do nothing, we're not addressing this at all, and we have to get through that. So there are various ways of getting through this and breaking up steps in this cycle to where we're not having this issue. But laying down for days at a time is not one of them. And I get it. People are in terrible pain and they're like, I can't move or do anything, but we have to just try to do what we can, because otherwise we're not addressing these areas as far as the chronic pain is concerned there. So that's really what to keep in mind is this thing keeps spinning. What we got to do is stop it. And that's what we're going to work on doing with various treatments that we can do. If we don't run it, it doesn't work. If you leave your car out in the snow and leave it covered, nothing's going to work. It's going to just stop working correctly. And that's what happens is we get in that cycle and it doesn't work properly. Our body is full of moving parts that we need to keep moving. And if we don't, that's when things start to break down. And that goes for your car, to your body. And that's why we have to work on getting moving the best we can. I always tell everybody when I see them that the enemy of inflammation is activity. And so the fact is, the more we're moving, the less we're going to have of this inflammation. And that's what we're trying to do. So in doing that, how are we going to do it? Well, there's a number of different ways that we're going to address this that we get into. But just a few more misconceptions on things that we see coming through the office as far as that's concerned. One, if I had $1 for every person that comes in at the end of our visit, the beginning of our visit, that wants an MRI, I wouldn't have to do this lecture anymore. Because the fact is, in actuality, there's very few indications for an MRI for a patient at a first visit. Visits after that, absolutely. When you've gone through conservative care or various things, or if you've had other treatments through another provider, then sure, that's certainly an indication. But, first visit, not having any treatment and basically your nerve function being intact is not really an indication for an MRI. Another one of my adages that I've developed over the years is I always tell patients, whether it's an MRI or labs or whatever it might be, I never try to order tests that aren't going to change our treatment path. And as we go through this talk, you'll see our treatment path initially is not something that you need an MRI for. So that's why we don't order it. But I have people that get really mad in the office when I tell them you don't need an MRI, and they will argue with me. And we try to hold fast to what's best for the patient, and that's what we're doing. So an MRI is not something that we jump right to. Now, of course, there are indications for an MRI. So what are those? So failure of conservative care. So that means you come in to see me, or we've seen you and you've been through therapy and you've tried various medications, all for, depending on the insurance, 6 or 8 weeks or whatever it might be. And the fact is, that is certainly reasonable to do, and we don't have any issue ordering an MRI, but there has to be a reason to do it there. Pain which limits conservative care. So if you've either gone to the chiropractor, gone to therapy and tried, and it made your symptoms worse, or you couldn't tolerate it, then again, no issue, we order the MRI. Red flags are more things that in someone's history that we see that this is certainly something we need to do an MRI sooner than later. The one that they drill in your head in med school is the bowel and bladder incontinence. I very rarely have someone come in the office with that, but that's usually right to the ER because that's a more significant issue. But normally, if you come in and have a history of cancer, particularly prostate cancer, kidney cancer, breast cancer, lung cancer, those are reasons that we will get an MRI. And it's not that I think that everybody's back pain that comes in with those prior histories has cancer there, but that's what we do. Neurologic issues, if you have weakness that is getting worse, or weakness that when you come in you've had and is not changing for the better, or have had it for a while, those are certainly reasons to do an MRI. Other reasons are significant trauma to the back, which you can't evaluate that great with an x-ray, unexplained weight loss, steroid use, and IV drug use. So again, there are issues that we will do an MRI for. But again, the majority of patients that come in their first visit, we're not ordering an MRI. It's just not indicated. And why put you through radiation that you don't need when most of the time we will do conservative care, you'll come back in and you'll feel better. And then if we had ordered an MRI, we now have an MRI that we didn't need. And to me, it's not about, well, the insurance should pay for this because I pay for it. That's not the point. I don't work for the insurance company. I work for the patient, and our job is to get you better with the best way possible. So again, if we need to get an MRI, I have no issue doing that, but I also don't want to put you through it if you don't need it there. So some of these red flags brought up to my mind, another misconception that we have, at least in our office these days, is that tech is the enemy. And what I am addressing with this is that there's a reason why we have patients come in, we have you fill out your stuff on the iPad ahead of time, or when you come to the office, because there's a lot of times not a way to get all that information from a patient as far as other symptoms that are going on. We need to get an idea of other things that are happening, such as those red flags that can say, hey, this is why we have to go this direction. It helps us to communicate better with other doctors within the system as well. So, and I get the frustration. I go to Rothman for my own issues. I have to fill out the iPad. I get it. But it does serve a purpose in not only helping with communication between you and your physician, but also communication between your physician at Rothman and your primary physician, and communication in those aspects. So, a lot of times patients will come back to the room frustrated with that, but I try to at least help them get through that part of it so we have a better idea from a symptom standpoint what we're dealing with there. So another misconception that we have is that patients come in, they automatically have their MRI reading. It says, I have 4 disc bulges in my back, so that must be what's causing my pain. Well, they've done multiple studies with this, and I'm not one to necessarily go quoting a bunch of studies to patients because they don't really necessarily care about that. But the point is that they've done studies where they have folks, they do MRIs on 100 patients, and they do the MRI, and 60% of them end up having a disc bulge. And of those 100 patients, none of them had back pain. So for the most part, disc bulges are not something that is causing a symptom. And when I show you some pictures of them later, you'll see why that is the case, is because of how they're situated anatomically and around where the nerves are. So most of the time, a disc bulge is not causing symptoms. Another thing that I try to emphasize to the patient is that we don't treat an MRI. And that goes to the disc bulges, disc herniations, or whatever it might be, or x-rays. The x-ray or MRI is only part of the proverbial picture. And I say that way because it is a picture, but it's not the patient. And you can have someone that has a terrible looking MRI or a terrible looking X-ray and has no symptoms from that. And you can have a patient that has a MRI that just shows a little bit of findings, but has much worse symptoms. And that's the science of medicine and how we treat things, is that everybody's different. If everybody responded the same way to every treatment in medicine for blood pressure, diabetes, or any of this, med school would be a lot shorter. But that's not the case. And that's what they call, quote unquote, the art of medicine, is you have to be able to use all these things, these tools at your disposal, to get the patient to where they need to be. So, as I just said, if your imaging is not consistent and history is not consistent with what we're seeing, then, whether it's an injection or medicines for whatever aspect we're seeing on that MRI, that's not what we're treating. This MRI again shows a fairly significant disc herniation here, but this patient may not have any symptoms from it. It may be from down lower, or it may be from a different nerve issue. So the MRI is just part of this, along with the history and the exam. That is all how we go about treating this. So we don't treat images, and I know I'm going to kind of beat this to death a little bit, but that's why, because you get caught in treating that, and then you're not treating sometimes the issue that we're looking for. So what does a disc herniation look like? So there's basically a couple different stages that we look at here. You can choose any one of these pictures. This MRI, that's a pretty significant what we call disc extrusion, in that the disc is herniated out and up or down. So when we talk about a disc bulge, basically, and the outer part here are these very tough fibers, and then the inner part, it's kind of like a jelly donut. So you got the jelly in here, and these inner very tough fibers, like small ropes that are all wrapped around each other to keep that disc in there. So first thing when you look at a disc bulge, it's not coming through this area whatsoever. And the size of it, your nerves sit out in these areas here, so this disc bulge is not going to be causing you an issue. The further along we get, a disc protrusion is just more of this pushing on and straining these fibers. So eventually these fibers start to give, and then you break through that. And that's when you'll see kind of this, the jelly of the disc leaking out there. That's what we're seeing on this big disc over here. That's basically an extrusion. And an extrusion is more of a radiographic term. And what that means is that the disc is pushed out, but it's either pushing out either up or down, not straight back. And the last one is basically a sequestration. And I apologize, the last part of that got cut off there. But that's basically, you can see in the upper picture and here, that's when an actual piece of the disc becomes floating around in that area. There, and you get basically a fragment of the disc that's sitting in that space there. But again, we don't treat these, and even in the worst case scenario of some of these, 90% of the time, as we mentioned, they're getting better. So imagine it like the jelly donut. Is you have this nice solid area around the jelly, and then the jelly's inside. So when these fibers start to strain and become weak, that's when that pushes out into that space there, and the jelly gets squeezed out of it. I put the next two slides in it just because I was at a lecture once, and I thought this was really a good way of showing patients that you don't treat the picture here in general. So if you look at the picture, you don't just treat it, because you look at it and you say, well, this is not a good look for you, right? So then when you look at the rest of the photo, it's not always what it seems. So you take all that into account as far as what patient's symptoms are, the picture, and put it all together. And you make sure that basically treat the patient, not the picture, and make sure things are consistent with each other. Because if they're not, you're going to end up treating something that's not bothering the patient, and you may end up doing them more harm than good with that. So we have to make sure we're doing that. I'm done beating that. I'm sorry, but I always try to tell patients that on a regular basis. So, all right, another one. So the misconception is patient will come in and say, I'm not having any back pain. And, for nothing in medicine is 100%. However, most of the time, and speaking specifically of disc herniations, most of the time patients don't have back pain. It's all leg pain. And why that is because the anatomy where the disc sits and is pushing on the nerves is hitting the nerve after it would bother your back. So that is anatomically why you get the leg pain. Now, the diagram at the bottom, I put in there because people come in with a generalized understanding of sciatica, and they'll be like, well, I'm having sciatica, and they'll say, well, I'm having pain down the front of the leg into my top of my foot, or I'm having pain along this area. And it's a very general term, and it doesn't bother me one way or the other. I have no issue with that. But for the most times, patients aren't coming in with symptoms that are sciatica. They're coming in with symptoms that are invariably one of the five nerves in your lower back that's being affected there. And so, some of them will go down into the inner part of your leg, the outer part of your leg, the top of the leg, the back of the leg, in the groin, down the front of the leg to the top of your foot. There's varying patterns of those pains that are each associated with a specific nerve. So, when you do an MRI, the radiology reading doesn't come back. You have a disc herniation on the sciatic nerve. That's not what it says. It'll come back and say, well, you have a disc herniation that's affecting your L5 nerve, and that would be why you're having your symptoms. So very rarely does someone come in with straight-on sciatic-based symptoms, though it does certainly happen. But most of the time, it's a more specific nerve root level that we're looking at there. So, that's why when you come in, folks will say, I have much more leg pain than back pain. Now, folks will say, well, I'm having all this. Why can't we just start with an injection? Well, injections and medications are not preventative. And so that really is not ever our first line of treatment, because I'm not in the office as a physician and treating you so we can just get rid of your pain one time. You come back in 6 months and we do another shot. We want to get things better for the long haul so you don't need an injection. And we want things to be proactive with that as far as treatment is concerned. So conservative management usually follows one of a number of different things. So one is physical therapy, the other is medication, the other injections, the other is bracing or stimulator, various other what we call modalities. But only one of these is prevention, and that's therapy, and that's why we do that first. Now, what therapy isn't is something like this. What it more is probably a combination of these above things in moderation. Are we going to have you running 8 miles an hour on the treadmill? No. Are we going to have you doing deadlifts of 400 pounds? No. But all of these things, whether it's stretching, strength, or endurance and things like that, are all part of how we're going to treat things, just not in the extremes that patients think. And the other argument I always get from patients with therapy is, well, I do my own exercises at home, which is certainly true, but there are certain things the therapist can do that you aren't able to do at home, which is why, we recommend going into therapy, at least in the beginning. The worst case is we have you go a little while, they give you the exercises to do on your own, and then we progress from there. So in therapy, there is a stepwise process, and this follows the same treatment options, whether we're treating your back, you're seeing someone for your knee, your shoulder, your elbow, whatever it might be. The process is the same. The first is A, to lessen the pain you're having. B is to improve the motion and flexibility of whatever area we're treating. 3 is then improve strength. And that's no matter what the cause. And I have patients that we will set up therapy for 4 weeks, have them come back at the end of the 4 weeks, and they'll be like, Doc, I haven't touched a weight yet. And then I will go over this with them. I'll be like, have you been doing this? Have you been doing that? And then you'll look at their therapy script, and their motion's not quite where it needs to be. So we don't want to, if you don't get the first 2 fixed to the level they need to be, your strengthening isn't going to matter, because you're not going to maximize that if you haven't lessened your pain and improved your mobility. And again, that goes for anything, whether it's, your lower back, your neck, or your shoulder or knee, any of those things that you are treated with physical therapy. Now, there's different types of therapy, more so than I can get into in this lecture. One is what we're kind of do on a regular basis, which is what's called land-based therapy. The other type of therapy that I like is aquatic therapy. And aquatic therapy is not you getting in a pool and swimming before people start thinking that. But the reason I like pool therapy for back patients is it eliminates gravity from the situation and allows you to do more without having gravity affect you. And also, you're able to use the resistance of weights uh, in the water as opposed to having to deal with heavier weights outside of that. And a lot of my patients have other joint pains, so that all is much better for patients in aquatic therapy. And I've done lectures 20 some years ago when I started on aquatic therapy, and there was maybe one place in the entire area where you could go. Well, they're much more prevalent now because we found the success that they can help, particularly in folks that have been through regular therapy and have not had success there. So the arguments I get from therapy from patients, and I get all these. So one is the cost. It used to be, and I don't ever like to show my age, but it used to be in therapy was never an issue with insurance. It was covered lock, stock, and barrel, no cost to the patient. But that's not the case now. A lot of insurance patients have a large copay with that. So, if we feel that's going to be a barrier to getting better, then we will try to get them home exercises to do there. And anytime I give patients home exercises, I tell them I don't want you to feel you need to do these twice a day, every day for the rest of your life, because I'm a realist. People have lives and we need to be able to do what else we want to do. But if you can do those exercises a couple times a week, it will certainly go a long way towards helping you as far as preventing this down the road. It does take time. I can't change that. But again, if you have the exercises at home, you can do that when it's convenient for you. If we give you exercises for your neck, you could sit there at work at your desk and do most of those there. The toughest one is the last one, the P word, or persistence. And why that is because I send you to therapy. It's easy to do the exercises because you got somebody there that's working with you. The tough part is keeping them up when you leave and you're done with therapy, because then you have to basically motivate yourself and do it yourself. And that's the tough part. So, anybody can go do therapy twice a week for 4 weeks and most likely get fairly good results. It's keeping that up in the long term that we really strive for. The therapy basically acts as a bridge. So where we are over here is the disc pain that you're having and the fact that we need this disc to heal. And so we need something to help us get to this area and managing our pain across this bridge. And that's one of the things that therapy does, is it kind of guides you along that way. Now, the other issue I have these days is, that people don't want to do the work. They want an easy answer. So that's why folks will come in and say, I just want to get an injection and I want the pain to be gone. And, I like doing injections, but that's a disservice to the patient. And by not having them do the hard work that is going to be necessary to give you the long-term results. You are never going to get long-term results from an injection or medication. It just doesn't work that way. That's why we have to do the work, whether it's, the therapy or the exercises on our own, because that's really what's going to drive us to get there. The other reason with the therapy part of this is that is you getting yourself better. There are very few things that we do that in our lives that make you someone feel better than you progressing and getting yourself better through the work you're doing. And that's another reason why, I think therapy is valuable, not only from a physical, but a mental standpoint there. So that's really what we're looking at with that. So, the misconception about a lot of injections is that it will fix everything. Now, first of all, it doesn't cure anything. The injection basically, as you kind of referred back to the diagram that I showed you earlier, it basically is to help break that cycle of inflammation. And it's just another way to do that, along with the movement from therapies and exercise and things to that effect there. They do not change anatomy. They do not affect how the nerve is functioning. The goal of the injection is to reduce inflammation. It doesn't speed up the healing process. Your body has to do that on its own. There is no therapy, there is no medicine, there is no injection that is going to speed up a herniation of a disc. Any of those treatments we're doing is basically managing your symptoms. And again, of those three, the therapy is the only one that really is driving as far as preventative is concerned there. So, I always try to correct what injections we're actually doing and what we're looking for. So what do injections do? Well, it's a great question, and I'm not trying to bore you with chemistry as far as things are concerned. But what we look at is this nice big topic of inflammation. So you have the disc that gets hurt, you have tissue injury and nerve injury. They release all these fun little chemicals that create another chemical, and then we have to figure out how to block it from getting to this area here. So on this side, you have anti-inflammatories, which work to block the conversion to what we call prostaglandins and thromboxanes, which are chemicals that create inflammation. And over on this side, you have the steroids, which work at this level and this level to try to help lessen creation of lipoxygenase and inflammation-based pain as well. So that's really how the steroid addresses things. So again, there's nothing on here that's changing your anatomy. Basically, we're changing the chemical property of inflammation-based pain there. So that's what we're doing with the injections. That's what the goal is. So why does it matter what's worse when patients ask me, and I ask them, I should say, what's worse, my back or my leg pain? Well, that is a key component of what type of injection you'd be looking at. And so that's why that is, again, important. In going back to that whole point on the tech part of this, is that we need to know what's worse for you, because that helps drive what we're doing and what we can approach this from an injection standpoint should it come to that. So types of injections that we look at are epidural injections, regular joint injections, facet injections, and SI joint injections. There are many different types of these variables that come off of these subsets of injections, and it's really impossible to address them all in this topic, but we try to hit the main ones that we're doing in the office to help alleviate the symptoms you're having. And, the most common one that we most likely do is an epidural injection of varying degrees. And so most of the patients ask me this question, well, is it the same as one that I had when I had a child? And basically in name and space only. And what I mean by that is the injection is still done in this little epidural space, but instead of putting a catheter in there, we put a needle in there, inject medicine, and take the needle out. And it's basically called a single shot epidural. And that's basically we do the injection, take the needle out, and done. Single shot there. The other is you're not having a screaming child that's trying to come out either. So furthermore, the injections when you're pregnant obviously are done without x-ray. Ours are done under x-ray and definitely much more easier from a physician standpoint, being able to visualize the landmarks for the injection itself. Finally, when you're pregnant, the injection is more of a straight lidocaine or numbing-based agent, where the injection we do is all steroid because we're looking for longer-term relief with that. The different types of epidurals are, one is called an intralaminar injection, the other is a transforaminal injection. The interlaminar injection, as we'll show you, kind of goes between the vertebrae. A transforaminal injection goes around the side where the nerve comes out. A caudal injection is through the tailbone, and we'll try to cover some of the injections for each of these. Basically, the types are defined by technique as far as the location as the needle is concerned. So what happens once you decide in the office that you're going to have an injection? So first thing is we do some paperwork in the office, and we have you fill out some paperwork, and then you meet with my scheduler and we get you scheduled for the injection. Now, some things that we have to do beforehand are certain patients. If you're on blood thinners, we have to work with the physician that has you on the blood thinners for them to be able to hold them. And we take care of that process. We try to lessen any burden on the patient as far as that's concerned. And we also have to make sure your diabetes is controlled. So we will check your blood sugar before the injection there. If you're on Coumadin for a blood thinner, we have to make sure your values are good before we do the injection there. Obviously, we talk a lot about the injection before we actually get you scheduled there as well. Um, Usually your only concern is to show up for the injection once we've kind of got all the instructions from other physicians that may be treating you for other issues there. The injection itself, most of these we do in the office. So it's just like a regular office visit. You come in, you check in like you normally do, but instead of coming back and going in the exam room where we normally see you, we basically bring you in to where we do the injections and set you up and do the injection. You're there for about 10 minutes. You hang out for about 10 or 15 minutes more, and then we're done. Now, when we look at the types, the interlaminar injection, basically the lamina is this area between the bone, so the needle goes into this space there. When we do this type of injection, the medicine will spread up and down as well as right to left. And when we do the injection, obviously we give you some numbing medicine beforehand. You feel a little pinch and burn from that. When we do this type of injection, most of the time when patients describe the feeling, it's more of a feeling of pressure than anything else. Sometimes you'll feel that down your legs, sometimes you won't. If you felt it one time and didn't feel it the other time, it doesn't mean that the injection is going to work or not going to work. Basically, that has no bearing on outcome there. After this injection, you hang out again for about 10 or 15 minutes, and then we see you back afterwards there. The next type of injection is what's called a transforaminal injection, and that injection is basically named for where we do the injection. So the foramina is the opening where the nerve comes out, subsequently going down your legs there. And these injections tend to work better in patients that have a disc herniation and specific pain radiating down one part of their leg there. The injection is still a steroid-based injection, still done under x-ray. This dark stuff you see is a little bit of contrast, so we make sure we're in the right area. Basically, this is the pattern of the nerve as it comes out from the vertebrae and starts to go down your leg. The process is the same. You have this injection, we have you hang out for about 20 minutes or so afterwards, and then we see you back a few weeks for reevaluation there. So, side effects. So, most of these side effects that are listed are going to be from the steroid itself. And I'm referring to the facial flushing, anxiety, sleeplessness. Those are all things that come from the steroid itself. They last a day or two and then go away. Sometimes folks may get a slight elevation of their blood pressure, which can lead to having some headaches. They usually resolve on their own. There's not typically a lot of increase in pain after the injection there, unless we've kind of had to poke around there a little bit. But being that they're done under x-ray, that's not normally the case. Usually for the first day or two after the injection, we don't like you using heat back there. We prefer ice as far as that's concerned. The high blood sugar, usually that is due to someone that has diabetes, and there's no rhyme or reason to this. I have patients that have diabetes, we do the injection, they never have issue one with blood sugar after an injection. And then I have patients that it always is an issue. So that's why we always have the doctor that's treating that on board in case it is an issue. Now, it doesn't usually become a long-term issue as far as your blood sugar is elevated for 5 weeks. It goes up, and not even that day, but a day or two after, and then it usually lasts for a day or two, and then resolve there. The spinal headaches are a whole nother topic there, which can occur with epidurals. Most of the time they are treated conservatively and will get better on their own. The best definition of these headaches are positional. And what I mean by that is if you're laying down, usually you don't have it. But as soon as you get up, you have a lot of pain in that area. That's pretty typical of a spinal headache. They're, again, usually managed with fluids, caffeinated beverages, and we kind of see how you do from there. There are more advanced treatments for that, but normally we don't get to that need. So, how long can an epidural last? So, this is the point where I disappoint patients all the time. Is they'll ask me, well, first of all, onset is usually 7 to 10 days, sometimes up to 2 weeks. How long will it last? How many will you need? How much relief you'll get? I don't know until we do it. Everybody's different. There's no way to look at you, look at your MRI, and say you're going to get this amount of relief or it's going to last this long until we actually do it and see how you do. Again, what you feel is, you may feel a little bit of pressure when we do the injection. That's otherwise about it. As far as being paralyzed, the only reason you should be paralyzed, or that's a chance of this, would be is if you were on a blood thinner or or had an infection or something that was compressing the spinal cord. But otherwise, we're out of that area. We're well below your spinal cord and not in the same space. So that really shouldn't be an issue, particularly with routine interlaminar epidural injections. Other things, I work in an orthopedic office. Invariably, my patients are getting injections from other doctors. So you have to keep track of other injections that you're getting, because it doesn't matter whether this steroid you got is from a epidural injection or a knee injection, it's still a steroid. And you have to keep track of how many of those you get over a time frame there. So that's really the biggest thing. Now, for consideration of surgery, that's for another topic as well. But again, surgery is folks that have had all conservative care, have had injections, and continue to have leg symptoms, because surgery does not help back pain. It only helps leg pain. And that goes back to that initial picture I showed you with where the disc is pushing on the nerve. That's why back pain doesn't get better with surgery. It's not that it can't. It's just if you go see a surgeon and you say, I have all back pain from my disc herniation, they will not operate on you. So lastly, facet joint injections and medial branch blocks. So this is kind of the hot topic over the last number of years because we're always trying to figure out what we can do to help patients' back pain. And there are numerous structures in the back that could cause pain, ranging from the disc to these facet joints. So facet joints are basically joints just like any other joint, like your knee, your shoulder, your elbow, except nobody talks about them except spine doctors. And what they are is they're joints that help provide your spine stability. And they basically, you have one on each side of every vertebrae from your neck down to your lower back. And again, they help keep your spine in alignment. And where do they cause pain? They usually refer pain along the back, into the buttock area, occasionally into the sides or front of the leg, but not normally below there. The treatment for these is always conservative. Again, therapy, exercise. We don't really start talking about injections unless we've done those things. The thing with these joints is they typically, though again, nothing in medicine is 100%, cause primarily back pain, and particularly when we're bending backwards. Because if you look at a model of a vertebrae, the basic joints that we're talking about sit in the back part of the vertebrae and subsequently will cause pain when you're bending backwards there. So that's what we're looking at there. So as far as that is concerned, that's where we normally see these addressed or pain causing. And again, kind of referral pattern ranges, you could see wide range of this, but most of it is in the lower back. Very rarely do I get patients that have referral down into the legs that far that get relief from doing these injections there. So how often can you do injections? Well, the interesting thing is over the last number of years, the way we treat these has kind of shifted a little bit. It used to be that we did primarily steroid-based injections into these joints. Well, what we found was that wasn't the best for the patient. And like anything else in medicine, you live and learn, and it wasn't that they didn't help patient, it was just that we were doing these injections over and over, and patients were getting a lot more steroid than they needed. So what we started to do was address the nerve that goes to that area. And what that is called the medial branch nerve. And those are nerves that basically originate from above and below the joint that go into that joint area. And they only go to that area. They don't go anywhere else. They are not the big nerves that go down your leg. That's why we can do this injection, is that, we do this injection primarily with a numbing based medicine because it's not going to affect your legs or anything. It's basically done around these nerves. So the thing I always tell patients and when we do them is that, if we're just doing one joint, it's two injections because you have to block the actual nerve at that level and the other nerve that contributes to it. So how often do you do them? So the way we do them is we do a set of them and see how you do. If you get complete relief and things don't come back, then we don't repeat it. If we do the injection, you get complete relief, it comes back, then we repeat the injection. If the same thing happens again, then we take a further step, which I'll describe in a slide or two there. These injections, unlike the steroid injections where you may need to wait a little bit for relief, these are usually fairly quick as far as relief-based injections are concerned there. And why that is because it's a local anesthetic and they tend to work much faster as far as things are concerned. So that's why, when we do these, we usually will give the patient a pain diary to fill out over the first 24 hours or 48 hours as far as their pain is concerned there. These are the same thing. They're done under x-ray, just like the epidurals. You come back in, check into the office. We take you back where we do the injections. We have you hang out for a little bit afterwards there. So then that leads us to the misconception that everybody that comes in is a candidate for getting their nerves burned. And that's not the case. The only people that are candidate for that type of procedure are those that have isolated back pain and that have had relief from these medial branch blocks. You can't do nerve burning of the huge nerve that goes down your leg into your foot and your ankle. You won't be able to walk. It doesn't work that way. The only type of nerves that we can do these are nerves that go to these specific joints for this specific issue. So that gets us to the big topic of the day, which is radiofrequency ablation or RFA. So basically what it is we end up burning the nerves that go to those joints. And again, why you can do that is because those nerves don't go anywhere else. They only go to those joints and they're very specific to that. And the procedure, from a standpoint of how much involved more is it than the actual injection, it's not a ton more involved. It used to be you had to go to a surgery center for this. Now we do them in the office because we have the equipment in the office. But instead of putting a needle in there and injecting a local anesthetic, what's done is we put a probe into that area and we burn the nerve. So we do this in order to provide long-term relief in those that have had success with the medial branch blocks for those facet joint-based pain. So when is it done? So these are done after you've had 2 sets of successful medial branch blocks. Not everybody ends up needing this ablation. Sometimes we'll do those medial branch blocks and their pain won't come back. And then you don't end up needing the ablation. So a lot of times I won't even bring this up to patients unless we get into the second go round there. How long does an ablation last? Well, I'd love to sit here and tell you it's permanent, but it's not because these little nerves can regenerate. So the hope is 6 months to a year, and you can repeat that. Now, the rules of whether you have to go back through the entire process or not before you do an ablation have kind of shifted since COVID. Now, if you've had an ablation within a year or so and it worked, they'll let you just go back and repeat that as opposed to going back through the whole testing of the nerves and doing the other nerve blocks first there. So again, basically this is kind of the probe we use. It's done under x-ray and we end up isolating that nerve that goes down into these joints there. And so the thing I caution patients with this procedure, and what I mean by caution is expectation wise, the other injections you got pretty soon and pretty quick relief. With these, takes time. And just think about it. We're putting this probe in here and we're burning that nerve. It's going to create some inflammation. So you got to kind of wait for all these things to kind of chill out and calm down there. So you may actually have a little bit of increased pain afterwards there. And so it does take a little while, sometimes up to 4 to 6 weeks to notice whether you got relief from that. So I always try to tell them, that it's going to take a little bit longer. So don't expect things to go away right away, because that's not necessarily what's going to happen there. So briefly on other joint injections, what we're seeing here is this is an injection of someone's hip. A lot of times these are done to either try to help lessen the pain that patients are having or to diagnose if your hip is actually an issue. These are done typically under x-ray or ultrasound. Why that is because though everybody invariably has an idea of where their hip sits, hip pain is usually referred to the groin area. So most people don't want you just putting a needle in their groin without x-ray guidance or ultrasound guidance and seeing if you're in the hip joint there. These are pretty effective for patients, particularly those that have a lower grade of arthritis. If you come in and have fairly severe arthritis, they're not necessarily going to give you a ton of relief. You can have, you know, 3 of these a year there, as long as they keep working. And just to kind of backtrack a little bit with the epidurals, the rule of thumb is 4 over 12 months. After that 12 months, the number resets. So I apologize that I didn't hit that when we were there. The other injection that is one that we kind of do a lot of is what's called a sacroiliac joint injection. Basically what you're seeing in front of you is kind of a model of the pelvis. And why we end up doing a lot of these injections is this joint, which is kind of where your tailbone, your hip bones, and your back all come together in this area. So it's a fulcrum of where all these things are sitting. And that joint can get irritated from anything that kind of changes how you're walking activity-wise. A lot of times in patients that have had spine surgery, it becomes aggravated. Now, the interesting thing with that is, and why we end up doing a lot of these is, anatomically, the sciatic nerve sits right in this area and runs right down in front of that joint. And patients will get sciatica that's not coming from their back. It's created because this joint is irritated and it will cause pain that is similar to sciatica but not coming from there. You know, a lot of times I'll get a patient referred from their primary with a diagnosis of that. They'll come in and they'll have an MRI that isn't showing anything that would contribute to that. And this goes back to not treating the MRI. And then we do an injection in there and it relieves their symptoms. And that kind of gives you the idea that, hey, this was coming from that joint, not somewhere else, as far as that's concerned. So that's kind of the majority of joints that we do. Again, there are other ones outside of that, but for today's lecture, it's kind of where we're sitting there. So now is the point where I'm done talking, and now you get to ask all your questions. So, and I thank you for your attention because I know it's not the easiest thing to sit through, and hopefully you got something out of that talk. And, you know, if you come and see us or have seen me, you've probably heard me say a lot of the things that I already said during this talk there because it's kind of what I tell patients, you know? So that's what I had.
I think we all got a lot from that. That was super interesting. Do have some questions here in the chat. We'll start with, why does that say my name? Interesting. It says, regarding steroids, do you need to track total per month or cumulative over a year? What is the limit of steroids and over what time period? Long time harm of steroids locally and systemically.
So great question. And that's really why there's a limit on injections. If there was no steroid in the injection, you could do as many as you wanted. But the steroid is really what limits what we're doing. And again, that's why I mentioned, you know, when particularly working where we are, I'm getting other patients that have invariably had other injections. So the question is, so there's a number of different ways to address that. So if we're talking about repeating an epidural, we usually wait a month between. Now, the reason for that is basically we found that, you know, we try to build upon what we did already there. Now, if we talk about other injections, normally I try to space those out about at least 2 or 3 months apart. So like if you've had a knee injection, we're not going to do an epidural 2 weeks after that. It's just not a good idea. And that's why I said the cumulative amount is really the total number of injections, not just epidurals. So if you have 4 total injections over a year, we got to really kind of keep an eye on, you know, the amount of steroid that you're getting. And not that either a knee injection or a steroid injection for the epidural is a large amount, but it's the cumulative effects you have to, you know, you have to be aware of. So, you know, that's why we put the limit on that. So we're not doing any injections where somebody's had one and we're doing one in the same month. That's just not good for the patient there, as far as that goes. But again, as far as the overall time frame, it's usually the 12 months that we're looking at that we say, okay, then that number resets as far as that's concerned.
Okay. And I know this is a question I see in a lot of the lectures, so I'm sure it's something you hear a lot. What are your thoughts on PRP injections for stenosis?
So um, you can look at that a number of different ways. One is it's not been proven enough to be effective where insurances cover it. So that's one thing, is it's out of pocket. Uh, and two, it's not shown consistent relief, which is another reason why it's not been approved for that. The thing that I tell a lot of patients is, if I could, and usually the PRP a lot is used, and we've done trials at Rothman, and we've had patients that come in and will pay to get it done, but we don't do that anymore because they weren't getting any relief from it there. But the PRP injections are done a lot for what we call degenerative disc, which is to try to help that area that's worn down between the vertebrae there. But it's really not shown the same amount of success as it has for folks that have like tendonitis and things to that effect.
Great. Is it possible for bulging discs to heal on their own?
Yes. Now, interestingly, like if you look at the pictures that we had of the bulging disc there, it's not sticking out into the space as much. So it has a longer time and takes longer to heal than, say, a disc herniation that's pushed out entirely into that spinal space there. So they can heal on their own. And the rule of thumb, though, there's nothing to this. When I give this time frame, it's a time frame of, if you saw a change on an MRI. Doesn't mean you're going to have symptoms that long, but if you have a disc herniation or something, normally we'd like to see it, getting smaller within 12 to 18 months after things have started or initially injured there. Doesn't mean you're going to have symptoms that whole time, but we don't go do another MRI 3 months after your last one to see if the disc has gotten smaller, because it's not, most of the time it's not have gotten smaller at that point.
Okay. What are your thoughts on acupuncture?
Acupuncture I like for patients that have primarily back pain. I think it's a nice alternative, or if you've kind of gone the therapy route for things to that effect, uh, my experience with it has been that folks will get relief more of back pain than necessarily the sciatic based pain. And I will tell you that, the biggest and hardest thing I treat is not a disc herniation in someone that has leg pain. The hardest thing we treat is someone that has degenerative disc and has primarily back pain, because surgery doesn't help that. So you basically have to find something that's going to work for this patient, because surgery doesn't help that. Sometimes you're trying whatever you can to get relief from that there, um, because injections, at least epidurals, don't help with back pain. And if you've done the other types of injection, they haven't helped. You have to figure out other ways to treat it. And certainly acupuncture is one of them that we use. The nice thing is that some insurances, particularly Medicare, depending, will cover some acupuncture for that. So you can look into your insurance. Some of them will actually cover it. Now, we don't do that at our office where I am there, but there are places around that do it.
We have time for just a couple more.
I'll take as many as you want, as long as you
Okay.
want to do it. I'm sitting here, so
Okay. I'm just seeing a
I have
lot
to
of
deal with my
questions
kids,
about
so it's fine.
I'm seeing a lot of questions about arthritis and how it relates to back pain.
Okay. So without boring anybody with the process of how this causes pain, basically what happens is you have those two vertebrae in your back, and there's a disc between there. And what happens is over time, the disc starts to shrink. And as that disc shrinks, the bone gets closer together. And when bone gets closer together with bone, whether it's in your knee joint or your back, you get increased blood flow to that area. And when you get increased blood flow to area where there's bone, you get more bone formation. And when you get more bone formation, it's not good bone. It's bone spurs and things to that effect. And in the back, what happens is it starts to cause narrowing and irritation of the nerves that go to the muscles in your back. And subsequently, you can start to get pain in the back from that, because what happens is those nerves get irritated and they cause the muscles to tighten or spasm in your back. That's a natural reaction to an irritated nerve in that area. So that's why folks will get that. And there are obviously different other reasons why arthritis causes back pain, but that's pretty much the explanation I give the patients. When you get narrowing around that nerve and it gets irritated, depending on where it's being compressed, some folks get primarily leg pain, some get primarily back pain. So, but it's all kind of the same process. Is you get development of that extra bone in that area, and it starts to subsequently irritate the nerve that is traveling through there.
Okay. Are there types of oral pain medications for femoral nerve pain?
So the two medicines, so when we're talking about specific nerve-based pain, there's three that we typically use. There are always others, but the three that I primarily stick with. So one is called gabapentin or Neurontin. The other is called Lyrica, and those are medicines that work to try to lessen the firing of nerves. And they're not narcotics, they're not steroids, they're not muscle relaxants or anti-inflammatories. They're kind of in their own class of medicine. And no one's exactly sure of the mechanism of how they work, but we use them a lot to treat nerve-related symptoms there. The nice thing, and again, if you've seen me, you've probably heard this speech, but of medicines I write for, and we try not to write for a ton of medicines because they're not always the answer in the long term there. But in writing for medications, the gabapentin and the Lyric are probably the two that I write the most for because invariably my patients are on different medicines for different things, whether it's heart problems or things to that effect. And those medicines don't necessarily affect folks that are on blood thinners and things to that effect where anti-inflammatories will. Now, the downside to them is you do have to take them every day there. Usually, if I have a patient on it, we'll have them started on that medicine once a day, about an hour before bed, because sometimes folks will get some drowsiness with it there. Now, the medicine outside of those two is a medicine called Cymbalta or duloxetine. It's a medicine, if you went online and looked it up, it's a medicine we use to treat uh, patients with anxiety. Now, obviously, I'm not treating people with anxiety, I'm treating people with pain. But what we found is that medicine works on some of the same receptors that cause nerve related pain. And the nice thing with it is if you have a patient that hasn't tolerated the gabapentin or the Lyrica, then it is a nice medication, doesn't have the same side effects as that, and may give them another option with that. And if none of those work, you can always do a femoral nerve block and try to help calm the nerve down that way.
Great. Any cautions with rehab re-aggravating the cause or causing pain?
So the usually the pain that we are dealing with in rehab is more muscles that we haven't used before than things being reactivated by therapy. Now, does therapy sometimes make things worse? Sure. I have patients every day that come in and say, I tried PT and made my symptoms worse. And obviously, that's not our goal in sending you to therapy, but it can happen there. But a lot of the time, it's more so of, you know, I'm getting some of this pain in my back, but it's pain that I didn't have before because I'm now using muscles that I had never used before. And, it's all part of the longer term improvement that we're looking for. Now, whether it's at therapy or when patients ask me, well, what can I go to the gym and do or other exercise to do? You know, I always, and there's no medical science behind this, but what I tell patients is this, is if you go to the gym and you're doing something, you have a little discomfort when you're doing it, that's not unusual. But if the next day you can't move, then that's probably something that you don't want to do. And therapists get it, and they will certainly adjust their treatment program for you based on if things get flared up from them working with you.
Great. How important or helpful can your diet be for inflammation, arthritis, and pain?
Oh, great question. So, diet works a number of different ways. Obviously, we want to try to maintain a healthy weight. And by doing that, that will help lessen the strain on our lower back because internally, not to gross anybody out, but all of our organs hang off of structures from our lower back area. So if we lessen the frontal weight that we have, that will certainly lessen the strain on the back there. The other is, and I don't ever remember the exact number, but it used to be for every pound of weight you lost, that's 5 pounds of weight off of your back as far as strain goes. So it's certainly helpful to keep that area, uh, in the best shape we can. Now, as far as inflammation is concerned, obviously you can go into a full-blown anti-inflammatory diet, and I have patients that do that. I don't have a practice that's set up to do that whole part of it, but when we talk about things you can do inflammation-wise, the one thing that has been shown research-wise to help with inflammation, that when patients say, well, is there one thing you could recommend? I usually bring up turmeric to patients, because that's one thing that has actually been shown to help reduce inflammation there. And there's a number of different ways you can get that. And even if you don't like the taste of it, and it can help with inflammation. So as far as, I don't have a whole big thing to give patients about inflammatory diet, but the one thing I do tell them is as far as adding things, the turmeric is certainly something to consider.
Okay. They're asking about treatments for spinal stenosis.
Okay, so most of the treatments I went over are all will deal with stenosis as well. Whether it's back pain and leg pain from a disc herniation or from spinal stenosis, the core treatments are always the same. And it's therapy, medications, injections, and then if none of that works, surgery. Now, the difference with, though again, nothing in medicine is 100%, in patients that have stenosis versus disc herniations, a lot of time disc herniations tend to get symptoms more on one side or the other, where stenosis tends to be in the back, but also down into the legs on both sides there. And when we're dealing with this, particularly with the injections, is that, and this is my experience again more so than anything else, is when we do injections for patients that have stenosis, before we do the first injection, I tell them, I say, this is just my experience, but this is what normally happens is we may not get your pain gone from your symptoms of stenosis, but what we're going to enable you to do is do more of what you want to be doing before that pain of the stenosis limits you there. Obviously, we want your pain to be gone, but that is normally what I will tell folks as far as that's concerned there. And the tough thing with stenosis, again, this depends why you're having it. Most of stenosis is caused by multiple factors, such as wearing down to the disc, bone spurs, and ligaments that all get thicker or larger as we get older, causing narrowing in the spinal canal. Whereas if you're younger and get spinal stenosis, it's usually a disc herniation. Now, the difference is when you're younger and if you have a disc herniation that's causing stenosis, that disc will get smaller on its own over time, as we know. So your stenosis symptoms may lessen no matter what we do. Whereas as we get older and develop stenosis from the other causes, we can't change that anatomy. So what we have to do are things that are preventative to make it so it doesn't get worse and try to lessen the symptoms we're having at that time. But a lot of the treatments are invariably the same for that as the same as for disc herniation there. It's strengthening the back and the core and taking pressure off of those areas to allow your muscles to do more of the work and not put as much strain on the discs and the nerve area.
Great. Why is sciatica confused with sacroiliac issues? Seems like the pain is in the same general area.
Well, it is. And why that is because the sciatic nerve runs right in front of the sacroiliac joint there. So, most of the time, folks that have sciatica, it's coming from their lower back. But the sacroiliac joint is a great mimicker of sciatica in that it will cause sciatic-based pain that is not coming from your back, because it will cause irritation of that sciatic nerve as it runs through our pelvis in front of that joint and cause symptoms similar to sciatica that aren't coming from a disc or a pinched nerve in the back. They're coming from irritation of that joint there. And, the nice thing with those injections is that there are very few diagnoses I see where injections are normally first line treatment, but that's one of them. Because it's a pretty diagnostic injection. Obviously, we want to make sure that's where your symptoms are coming from, but it also is therapeutic. And in that, obviously, we hope it gets rid of your symptoms. But if it's not coming from there, that shot's not going to help you. And why I bring that up is you can do a lower back injection for someone with sciatica from the sacroiliac joint, and they may get relief because those nerves that go to your sacroiliac joint come from your lower back. So you're indirectly getting them relief where you're not actually treating the cause. Whereas with the sacroiliac joint injection, it's going right into the joint. So if it's not coming from there, it won't help. So that's where that injection is kind of nice, is if you fully suspect that's where it's coming from, they should get relief from the injection.
So what do you do then if there is no relief? What and is it then not the sacroiliac joint?
So then there's a couple different options depending where you are in the treatment regimen. Like if you've already imaged someone's back or they've already come in with an MRI of the back and there's nothing there that suggests it's coming from the back, then you could do a number of different things. One is you can do a test called an EMG test, which is a test that looks to see how your nerves are actually functioning, whereas an MRI doesn't really do that. Now, the reason to do that in someone in that case would be is you can get an irritation of a nerve in the back and it not be from a disc herniation, though, as I said, 90% of the time that's what it's from. You can get a nerve irritation that causes sciatica from your lower back and not have a pinched nerve there. And your MRI will not know, it doesn't show inflammation. So a nerve test is something we do in our office that can tell you if it's irritated. And if it is, then you can try addressing an injection around that nerve. If you've not done an MRI of the back, then certainly that is something you can do to see if there is a reason from that that is causing that joint pain. The third thing you can do is an MRI of that area of the SI joint and the pelvis area, because not only does the SI joint have the sciatic nerve running in front of it, it also has muscles that attach to the back part of it that can become irritated and create similar symptoms there. So that would be a reason to do an imaging of that. You know, if you've done an EMG and it was normal, and you did an MRI of someone's back and it was normal, then certainly it would be within your reason to do an MRI of that area to see if uh, the muscle is irritated, specifically what we call the piriformis muscle, because your sciatic nerve runs right between there, the two heads of your piriformis muscle, and it can cause sciatic base pain as well. So, you know, there's other evaluation tools we have to look at that, as far as if it would not get better with it, what we call a diagnostic injection.
Great, thank you. That was very interesting. What about radiculopathy? Any different focus on relief for leg radiculopathy versus pain?
Nope, that's kind of what, we were talking about, all the pain referral down the leg, that's all called radiculitis or radiculopathy. So,
Okay.
the treatments are all, based on kind of what we discussed there. Again, that by definition, that is pain that is radiating, so it's usually not isolated back pain there. It's usually pain. And again, very rarely does someone come in and have straight sciatic based radicular pain. It's usually along those, either, your second, third, fourth, or fifth nerve from your back. They all have specific patterns that they kind of radiate down your leg. And that's more so what I see than anything else in patients than someone coming in with straight sciatic based pain.
There's someone asking about associated groin pain, I guess
So
associated with back pain.
yep. So groin pain is can be caused by a number of different things, but normally in our situation, the two things we eliminate are, one is arthritis in the hip, which tends to refer pain into the groin. Normally, that's a case of looking at someone's exam, and if they have pain when we're kind of moving their hip joint around, that will certainly, it will give you a hint that they have something as far as the hip goes. As far as groin pain from the back, normally that is what we call your L5 nerve. That is the nerve that comes out of the lower part of your back, goes into the groin and down the front of the leg to your top of your foot. But nerve is the most common one we see as far as radicular pain is concerned, but it does make a stop in the groin there and can cause symptoms just localized to there. Again, not everybody comes in with the straight leg pain, the pain down those specific nerve patterns. Sometimes they'll come in and say, well, I have pain in the groin and I have pain in the top of my foot, but nothing in between. So, nerves are funny in how they act and present, and they're not all the same.
This is a good one. For low back pain, should you use heat or ice?
So my policy, or what I tell patients, is I recommend alternating heat and ice, because what we found is it kind of shocks the muscle back a little bit there. You obviously have folks that they have their preferences. I will have patients invariably come in for shots, and I'll look at their back, and you can tell they were using a heating pad. because what happens if you use a heating pad too long, you start to get changes under the skin that we'll see when we do the injections. So any of the two is fine in moderation, but what I've found is alternating them works best.
Recommendations on back pain associated with fascia, especially after prolonged sitting or other static activity.
So that is primarily addressed through therapy and a lot of times what we call modalities that they can use through stimulator or ultrasound can help reduce that type of discomfort. Sometimes doing localized injections into the areas of discomfort, what's called a trigger point injection, can provide some relief with that. That is something that you really have to stay on top of with the exercises because it can certainly go backwards there.
Um, what about when there is no pain, there's only numbness or tingling in the legs and feet?
Great question. So, um, if we find, and so let's say we assume that's coming from a nerve irritation in the back, injections do not help numbness or tingling. We could try them. They don't necessarily work for that. And I will not turn someone down in trying an injection for that, but sometimes that will help. Uh, the reason that a lot of times folks get that first is from an anatomy based standpoint. Not that I want to bore anyone with this, but if you look at a nerve structure, it's like a giant cable made up of smaller cables. And the parts of the cable on the very outer part of that nerve that could get compressed first are those that give feeling and cause numbness and tingling. So that means you're getting some nerve irritation on the superficial part of the nerve itself. Um, if we find that it's from the back, then therapy still plays a role in that, and you could try to lessen the irritation of the nerve and lessen the pressure on the nerve itself. Also, there are those medicines we talked about, whether before, as far as treating a neuropathy. And a neuropathy, though most folks associated with folks who have diabetes and things like that, really the reality of it is a neuropathy is any type of nerve that is irritated there. So those are medicines you can try to help treat that. I have patients that have it, and I tell them, hey, your MRI shows why it's coming from your back. You can do this, this, or this. And they say, well, as long as it's not going to hurt me, I'm not going to do anything. So a lot of times folks are just like, well, wait until it kind of heals on its own, and we go from there. And that kind of brings me up to just something to touch on as far as healing of the nerve is concerned. And you know, the way a nerve heals is it's a distance factor. And so what I mean by that is the further away you are from where a nerve got irritated, the longer it takes to recover from that. So if you think about it, you have a nerve that starts in your back, invariably the part of it that heals last is going to be in your foot there. So people will come in and they'll be like, well, the pain in the top part of my leg and the numbness has gotten better, though I still have some in my big toe. That's not unusual. And sometimes it doesn't go completely away, but that is invariably a distance factor with that.
Great. How would you typically treat piriformis issues?
So piriformis is treated similar in that you always try it conservative based treatments first, including therapy and medication there, because a lot of times it could be a structural issue where the muscle is one side is stronger than the other, or it's more irritated than the other side, and then they you need to have a balance between the two sides there. If you've done those two things, then it used to be we did the injections just right in the office into the muscle, but there's some big structures around there. So what we've started doing is they do them under ultrasound there, where you can isolate the area where you're having significant tenderness, but also to avoid we don't ever want to do an injection right into the nerve, and that sciatic nerve kind of runs right through there. So there's not usually anything that surgery helps for that. As far as that's concerned, it's not really been something that's been found to help long term with that. That's another one you got to kind of stay on top of because it can come back on you if we don't stick with, kind of doing the basic exercises and things. And again, not saying do them every day for the rest of your life twice a day, but, a couple times a week, we'll try to help keep that from reoccurring.
How do you feel about the TENS machine?
So TENS, though, works differently. I would associate it in treating kind of the same thing, the same way that we talked about acupuncture. And it is the TENS unit tends to work much better with pain that is kind of just in the back. Um, I haven't had experience with it working that well as far as pain down the legs. It just doesn't get to the depth of the nerve in your back. And the same thing goes with acupuncture. That's why it really doesn't help with the nerve related pain down the leg. It tends to help much more with the back symptoms because we can try to address the muscles that are irritated in that area that are causing the back pain. But it doesn't, I haven't really found it to be great success with, and I'll have patients that we give one for and they'll try it along the side, but it's along the nerve in their leg, but that's not treating where it's coming from. So it's not going to help with that. So it tends to help much more with the kind of the back pain issue than anything else.
Why is my back much stiffer and painful in the morning?
See, that goes back to the first slide we had about pain and inflammation in that when we're not moving at night, so inflammation builds up and then we go to get up in the morning. Particularly, arthritis-based inflammation there. When we're not moving and you go to get up, you tend to have a lot of pain and discomfort. So that's why that's the case. Same as if when when I have to get up out of this chair after this lecture, I'm probably going to be stiff because I've been sitting for a while and that inflammation tends to build up there. So that's
Same.
that's why that happens.
Um, how about neuromodulation?
So that's an up and coming thing. Again, that's a way bigger topic than I could address in this lecture. And there's a number of different avenues that goes from just doing localized nerve treatment to doing what we call spinal cord stimulators, which are implants in people's backs that have been through the gamut of surgery or medicine injections and still have spine related or nerve related pain. And there are some docs at our practice that do degrees of that. And there, as I found just recently, there are neurosurgeons who just specialize in that type of treatment. And if I have someone that I feel needs that, that's who I'll send people to. I don't ever have an issue with sending someone outside of the practice because we're all physicians and basically we all have the same goal is to get the patient better there. Um, so it doesn't matter to me who gets you better as long as you get better. But the neuromodulation is, really it's really come about the last 10 to 15 years, but more so like the last 5 or 10 years. And just a quick blurb on the spinal stimulators. They're nice for patients because you can do a trial of it for 5 days and then they take it out. And then if it hasn't helped, you haven't lost anything. But if it has helped, then they talk about doing a permanent one for you. But again, there's so many variabilities that go into that. It's kind of more than I could even cover there. But it's a good use of things, particularly in patients that have undergone the surgical route already and either can't have more or don't want to have more and don't want to be on medicines. That gives them a nice option.
Okay, I think we'll just do two or three more here. What are your thoughts on trigger point injections?
So, trigger point injections are good for localized muscle-based pain. What I mean by that is pain that has a specific area that you're having tenderness to that, and it's not necessarily nerve related. What I mean by that is the big nerves in your back. Because if you do a trigger point on someone and their muscle tightness is coming from a big nerve in their back, it'll go away, but you're not treating the source. You're treating the result. So therefore, invariably, that's going to come back. Whereas if it's just an isolated trigger point that doesn't have an origin from a huge nerve being irritated, folks tend to do very well with that. The nice thing with trigger points are a couple. One is you do them in the office, you don't need x-ray, and they're very localized there. Low risk, and sometimes if patients are just having muscle irritation, they can get a whole lot of relief without a lot of risk that's involved with the injection there. There are varying degrees of trigger points. Some folks do them with steroids, some without. A lot of doctors, it really just depends on how you're trained with that. I do put steroid in mine, but sometimes if patients can't have steroid for whatever reason, we'll just do a local anesthetic there. And the theory behind doing trigger points is it breaks up the microscopic scar tissue within muscle there. Those are typically ones you end up repeating. Most folks, that's not one and done. You usually do them a couple times over a few months there.
Okay, and we'll make this one our last question because we still
Okay.
have like 50. So, like I said earlier, if you still have a
I
specific
appreciate all the
question,
questions, believe me. But
listen, we're all suffering over here. Um, so we'll call this the last one.
okay.
Are vibrators or the belts with the rotating balls good or bad for back pain? I feel like I see people buying those a lot and using them, so I think this is a really good
I,
question.
I I
It does
think
provide some relief, but I'm concerned about doing further damage.
so. It's not going to do any damage. It's basically kind of just trying to relax the muscle or kind of break up the tightness in the muscle. And I'll equate this to uh, you know, my for good or bad, my in-laws live in our house, and before they moved in, my father-in-law ordered without telling me, which is what goes on here, is he ordered and this is another one I get a lot of questions of, maybe even be some in there, are inversion tables. So we've ordered an inversion table for our house, and it comes, and then he's texts me to put it together. So I put it together, and I'm like, I don't even know what we're doing with this thing. So he never uses it. But I use it, and what I have found that it works for is to help stretch out the muscles there. And that can be a lot of what gives folks relief, kind of like with what the devices you're describing there. Um, Anything like that, or those types of belts or things, it's not opening up the nerves where the nerve is being pinched. It doesn't do that. If it does, it's very short term, and as soon as you get off of it, it goes back. What it's doing is helping to try to relax the muscles that are tight in that area there. And we know this because they've done studies where they have put people in traction, put them in a CAT scan, and that enabled them to measure the opening of the spinal canal where the nerve comes out, and they found that it increased, but as soon as you were off the traction, it went back. So you
Yeah.
can't
Yep.
live in traction that way, as far as that goes. So I kind of put those things along. That is, any type of brace is not good in the long term, because what it does is it basically replaces the muscles in your back from doing their job, and they invariably become more weak.
Mhm.
So that's really doing the opposite of what we want.
That makes sense. Listen, it's been so interesting, and I know we have so many more questions. It's just more than we can get to. But thank you, Dr. Molter. This was just super, super interesting. And based on our turnout, I think everyone really got something from it. My phone number and email are in the chat. If you want to discuss further or schedule an appointment, you can always reach out to me directly. And again, thank you so much, Dr. Molter, for taking time to share your knowledge with us.
Thank you to everybody for sitting in and listening. It's boring, I get it.
It's not. Alrighty. Have a great night, everyone.
Thank you,
Thank
everyone.
you.
Appreciate it. Thank you, Kristen.
Thanks.